Okay, today we're going to tackle a really fundamental concept in obstetrics, one that honestly causes a lot of confusion: abnormal uterine action. Trust me, getting a solid grip on this is absolutely essential for managing labor well. So let's just dive right in.
So, you've probably thought about this classic clinical question, right? You have a patient in labor, you can see she's having contractions, but nothing's happening. The cervix just isn't dilating. So what is going on? Well, the answer almost always comes back to the quality of the uterine action. And by the end of this quick explainer, you're going to feel so much more confident diagnosing exactly what that problem is.
But hey, before we can understand what's abnormal, we have to be rock solid on what's normal. So let's start there. Let's establish our baseline and look at the perfect synchronized rhythm of a truly effective labor.
The single most important concept, and I mean the most important, is something called uterine polarity. The best way to think about it is like a perfectly coordinated wave. It all starts from these two little pacemaker points at the very top corners of the uterus, the cornua. They start the contraction, which is strongest right at the top, at the fundus, and then it sweeps downwards, getting a little weaker as it goes. This top-down pattern is what we call fundal dominance. Now here's the magic. While that strong upper part is contracting and pushing, the lower segment and the cervix have to relax and open up. It's this beautiful coordination that efficiently pushes the baby down and gets that cervix to dilate.
And what's really cool is we can actually measure this perfect wave. Just look at this graph. Between contractions, see how the uterus has this low resting pressure? We call that the basal tone. And this is so important because that relaxation period is when the placenta gets to refill with blood and the baby gets a fresh supply of oxygen. Then bam, the contraction builds to a really powerful peak. We're talking up to 60 millimeters of mercury, and that provides the force you need. Then it goes all the way back down to that low resting tone. This effective cycle, this is the real engine of labor.
All right, so now that we have a clear picture of our normal baseline, let's get into what happens when this engine starts to sputter. How do we even begin to classify the different ways it can go wrong?
This flowchart right here is basically our roadmap for the whole topic. It shows you the main fork in the road. At the end of the day, the problem is either with the power of the contractions, even though the coordination itself is fine, that's what we call normal polarity, or the problem is with the coordination itself. It's become chaotic. We call that abnormal polarity or incoordinated action. So let's explore both of these paths one by one.
First up, let's talk about the most common type of dysfunction you'll see: hypotonic uterine inertia. You know, the name itself gives you a huge clue. Hypo means low, and tonic refers to tone or strength. So put simply, these are just weak contractions.
So here's the crucial point to remember. The polarity is still normal. That top-down wave is still happening. The problem is that the wave is more like a gentle little swell instead of a powerful surge. You know, the contractions are too far apart, they don't last long enough, or they're just not generating enough force, usually less than 25 millimeters of mercury. And that's just not enough oomph to get the job done.
And how would you spot this at the bedside? Well, first off, the patient might tell you she's feeling less pain than you'd expect for active labor. And when you actually put your hands on her abdomen during a contraction, the uterus feels kind of soft. You can actually indent it with your fingers. But between contractions, it relaxes really well, which, by the way, makes it super easy to feel the baby's position. And the result of all this? A labor that is slowed to a crawl or just stopped completely.
Okay, let's completely switch gears and move to our second category. This presents a totally different clinical picture. This isn't about weakness anymore. This is all about chaos. This is incoordinate uterine action.
So what's happening here is that the fundamental principle of polarity has been completely lost. Instead of those two calm, dominant pacemakers at the top, you get these new, rogue pacemakers. We call them ectopic foci, that just start firing off randomly from all over the uterus. It's basically physiological chaos. The uterus is no longer working as one coordinated muscle. It's actually fighting against itself. This creates a really high resting tone, which means the uterus never fully relaxes. And the contractions, while they can be frequent and incredibly painful, are totally ineffective.
Clinically, this is the polar opposite of what we just talked about. The patient is often exhausted and in constant, severe pain. The uterus feels hard as a rock. It's tense and tender even between the contractions. That high basal tone is the hallmark feature, and it's dangerous. Why? Because if the uterus never relaxes, blood flow to the placenta gets seriously squeezed, which can quickly lead to fetal distress.
Okay, this next slide is definitely the one you'll want to screenshot for your exams, and remember when you're on the wards. It puts everything we just talked about side by side for a direct, super high-yield comparison.
So let's just walk through these key differences. Polarity? It's normal but weak in hypotonic versus completely abnormal and chaotic in incoordinate. What about basal tone? It's nice and low in hypotonic, but dangerously high in incoordinate. The contractions themselves? Weak and infrequent versus frequent but totally useless. And this all leads to how the patient feels. Less pain with a soft uterus in hypotonic inertia versus a patient in constant agony with a tense, rigid uterus in incoordinate action. And critically, this directly tells you how to manage it. You augment the weak contractions, usually with oxytocin, but you must first sedate and relieve the pain of the chaotic ones. You can't just power through chaos.
So let's wrap this up with the absolute key takeaways. Number 1, normal labor needs that coordinated top-down polarity. Number 2, hypotonic dysfunction is simply weak but organized action. Number 3, incoordinate dysfunction is chaotic, disorganized action with a high resting tone. And most importantly, your diagnosis tells you exactly what to do. You help the weak and you calm the chaotic.
And there you have it. At the end of the day, just being able to distinguish between weak, organized contractions and chaotic, disorganized ones is the most critical first step in successfully managing a labor that isn't progressing. Master this core difference and you'll be well on your way.